That's been one strategy that's been deployed, and it's been proven as pretty effective. Another strategy that's been deployed was to focus on the individual that possesses these risk factors. For example, we'd use a stay in the hospital on a correctional facility. Instead of just keeping them there, we take the opportunity to engage, assess, and plan. We would see where they're holding. We would see what they might be able to do. We'd see what they might be able to do on discharge. We'd see what they might be able to do when they get out of the hospital, when they get out of the prison, when they get out of the program. We'd assess and plan accordingly. That's another strategy that's been deployed that's been pretty effective. And another strategy that's been deployed has been to ensure continuity of care when transitioning from one provider to another. So, for example, someone that may have been in a state penitentiary, and they're now moving over to a detox program or drug rehab. So if we can ensure continuity of care when transitioning from one provider to another, there's a good chance that we might be able to prevent homelessness upon this individual's discharge from the overall system. So this is basically proving the point that most people that face chronic homelessness are typically burdens on the state's mainstream systems, and the state's mainstream social service systems. And because of that, these three strategies of either developing and implementing system-wide policies that prevent discharge to shelters or streets, of using the individual's stay at the hospital or correctional facility as an opportunity to engage, assess, and plan, and ensuring the continuity of care when transitioning from one provider to another, have been proven as very, very effective strategies. Other strategies that have been deployed and have been proven as effective were employing boundary spanners who understand and can engage cross-agency lines. In addition, helping individuals access housing. For example, how might that be done? By developing housing expertise within the mainstream systems, or perhaps providing bridge subsidies and priority access to Section 8. Again, these will all help the individuals that have these system and individual risk factors access housing. In addition, helping individuals access services that would help them get back on their feet. For example, linking people to services or teams that either provide or broker services, social services, and perhaps helping individuals gain access to benefits before they're released. These strategies have also been proven as highly effective. Again, either employing boundary spanners who can understand and cross agency lines, helping individuals access housing, either by developing housing expertise within the mainstream systems. For example, if somebody's incarcerated, perhaps, and they're, we know they're being released, perhaps if the correctional facility had some sort of housing assistance program specifically for people pending release. In other words, developing housing expertise within the mainstream system that would assist in preventing chronic homelessness. In addition, if bridge subsidies and priority access to Section 8 would be provided to these people or to the communities that face the individual and the system-based risk factors, that's been proven as well to significantly reduce chronic homelessness. Again, so by focusing on the prevention rather than the actual homelessness, the system might be much more effective. Other best practice strategies that have been deployed are collaboration and partnerships. For example, get all the stakeholders to the table. Who might be affected by homelessness? What neighborhoods might be affected by homelessness? In what way might they be affected by homelessness? How about the schools? How about a township? How about a police department? Homelessness will burden their budgets. So we have to get all the stakeholders to the table and develop partnerships. In addition, finding champions, developing incentives, stressing cost savings. Another key strategy is accountability. Holding systems/providers accountable for the outcomes. Establishing indicators with realistic benchmarks. And then incorporating the standards into contracts. Again, by collaborating and developing partnerships, or developing real accountability policies. These have all been proven to be very effective strategies in preventing chronic homelessness. Now let's take a look at some best practice examples. Okay, the specific example we'll look at is the transition specialists and the boundary spanners. The New York State's Office of Mental Health funds pre-release coordinators and a transition case management team to provide services to inmates with mental illnesses that are being released from the state prisons. Okay, so here we have an example of a facility that's providing in-house counseling and case management to prevent homelessness upon an inmate's discharge. The services include in-reach visits, linking to community housing and treatment providers, and coordination with the Division of Parole. That's an example in New York State. Again, the Office of Mental Health has a specific program for inmates that are being released from the state prisons to provide transition case management that include in-reach visits, linking to community housing and treatment providers, and coordination with the Division of Parole in an effort to prevent chronic homelessness upon the inmate's release. Let's take a look at Kings County in Seattle. Seattle as well has a program. The Mental Health and Addiction Services Division, they fund 4 liaisons to work with staff and patients at the state hospital to facilitate transition planning. Again, these liaisons typically work with the staff of and the patients that possess the individual and system-based risk factors. So again, we're trying to nip it in the bud. Let's take a look at some more best practice examples. Accessing housing options. Hawaii's Mental Health Division provides temporary rent subsidies to homeless patients being discharged. Again, this is an example of providing priority access to people that face the highest risk of homelessness. Section 8 rules were revised to give preference to people who are homeless receiving bridge subsidies. So there you go. You have the bridge subsidies, and then you have priority access to Section 8. So although in Hawaii they focus on the homeless as well, but there's a strong focus on those receiving the bridge subsidies, which means that they're about to become homeless. Kentucky, same thing. They made people being discharged from state hospitals a priority population for Section 8. And New York State, same thing. The Office of Mental Health in New York State mandated that individuals at high risk for homelessness, again, not yet, but they're high risk for homelessness, receive priority for housing, case management, and assertive community treatment. So there you go. We're trying to nip it in the bud. These are all cases of providing priority access to housing for those that are at risk of homelessness. Not particularly for those who are homeless, but for those that are at risk of homelessness. These are all examples of focusing on prevention. We've seen that in Hawaii, we've seen that in Kentucky, we've seen that in New York, we've seen that in Seattle. All these states have strong strategies focusing on preventing homelessness. We identify who's at risk of homelessness. We identify which individuals, which communities possess the individual risk factors and the system-based risk factors. And then we focus on those communities. We focus on those individuals. And we develop strategies in these cases, either active case management and or priority access to affordable housing. Let's look at some more best practice examples. Continuity of care and service access. Critical time intervention and short-term ACT services are evidence-based practices for people who've experienced chronic homelessness. Another example of continuity of care and service access is to provide intensive clinical services for 6 to 12 months during and following transition from shelters, hospitals, or jails. And it's been proven to be effective in maintaining residential stability, and it's been proven to be effective in linking to mainstream treatment and other support services.